Hey guys, welcome back to Clinical Physio. Today we are so lucky to be joined by a top-level orthopedic knee consultant who's going to be taking us through his clinical reasoning for osteoarthritis of the knee. We're going to be discussing diagnostic tips, management strategies for physiotherapists, but also key surgical considerations so that you know what these patients are going to be facing when they go to see an orthopedic knee consultant. So, without further ado, let's dive in. So today's guest is Mr. Paul Trikha, a consultant orthopaedic surgeon and knee specialist operating in the UK. His areas of special interest include surgical treatment and management of knee problems in adults and adolescents, knee sports injuries including complex cases, early and advanced knee arthritis, ACL reconstruction, joint preservation, full and partial knee joint replacement, meniscal and cartilage injuries and repair, patellofemoral dislocation and instability. He operates in several locations, including the Surrey Orthopaedic Clinic and the Shern Clinic in central London, and he and us would like to thank the Shern Clinic for their help in filming today's video. So, without further ado, let's dive in.
For osteoarthritis of the knee, where the diagnosis is OA rather than post-traumatic or rheumatoid, it's by far the most common, OA is. I think over 50% of all arthritis presentations in the UK are OA of the knee. So knees are a good place to be if you want to be busy. So OA, we talk about the knee being in three compartments: the patellofemoral compartment behind the kneecap, consisting of the patella and trochlea; the tibiofemoral compartment, the medial lateral femur and lateral tibia, medial femur and medial tibia, and by far the commonest is the medial compartment OA. So we talk about unicompartmental arthritis, or tricompartmental arthritis with all three compartments, or even bicompartment, depending on which compartments are affected. But unicompartment means just one of the three compartments, either medial, lateral, or patellofemoral. Okay, so the key when you assess any knee patient, being degenerative or traumatic or the injured knee, is look at their alignment. So we touched on alignment in some of the other cases we've done, but typically people who are bow-legged or varus have medial compartment disease. So you can almost guess what the x-rays are going to look like. People who are knock-kneed often have valgus, lateral compartment OA. People who've got the squinting kneecaps or the poor patella maltracking, the miserable malalignment of the kneecap, we call it, often a patellofemoral OA, and that's often bilateral. And then you can talk about the symptoms. But while we're talking about that, lateral compartment OA, think about rheumatoid, valgus knees. That's more of a typical picture. And in any exam situation, someone with lateral compartment OA with a valgus picture, you want to be considering and excluding rheumatoid arthritis as opposed to osteoarthritis. So we assess the alignment, and then for a warning, I'm looking at fixed flexion. I know we look at swelling and range of movement, but that's a given. But the key distinguishers for me are their alignment and whether there's a certain degree of fixed flexion or not, because that's typically a poor sign. Fixed flexion is a lack or inability to extend the knee fully, as opposed to bend the knee fully. So we're looking at alignment, we're looking at fixed flexion deformity, range of movement. This is on the exam, obviously. But then once you have that diagnosis of arthritis, you want to look at the joints above, make sure the hip or the spine aren't causing referred pain. Have a good look at the foot and ankles, make sure there's good pulses and neurovascular status in case someone is going to have surgery. You want to document that, as well as you want to, obviously the history is key in arthritis. And we talked about this last time. In assessment of patients, the history is key. So the patient will tell you the pain affects them every day, they can't go for a walk, they're limping, that affects their sleep, just walking around the supermarket, they're hanging on trolleys, they can't get around a golf course without taking painkillers. the thought of going to fetch a newspaper on a Sunday fills them with dread as opposed to joy. So it's the quality of life, activities of daily living, we call it, so ADLs.
And as you said, quality of life is a huge demonstrator or differentiator for you, for these patients. So if we're thinking about non-surgical options, your patient has said that they don't want to consider surgery yet. What might be available to them?
So I think it's very important for anyone who's assessing knees, be it physios, to be aware of the surgical treatments and surgeons to be aware of the non-surgical treatments, because the OA has a spectrum of treatments and they all are valid. And so the vast majority of treatment for OA knee is non-surgical. So if you look at the NICE guidelines, the clinical guidelines 177, I think NICE 2014, they're to be updated, but they're the latest ones as of to date. You know, surgery forms a very small part. So when you're thinking of treatment of the knee, the core treatments, 1, exercise, the right kind of exercise. Number 2, stretching and strengthening. And number 3, attention to body mass index, weight, and that's something we should all be preaching and practicing with our patients. Not just strength, but stretching and strength, the right kind of exercise, because we know it's good for coronary heart disease, diabetes, osteoarthritis, dementia, lots of things exercise is good for. And obviously, I know you've done some seminars on the role of nutrition.
Sure, yeah.
And how important that is, and I think all of us are pretty guilty of glossing over that one. But we do need to focus on what patients eat and why it's important.
No, I totally with you. It's often I suppose for some physiotherapists or perhaps some doctors, it's a difficult subject because you realise you're going to be quite personal with the patient. But I appreciate that, as you said, with osteoarthritis, it's a crucial factor when it comes to the knee. So.
Yeah, absolutely. And so that's the core treatments. But then the next layer out is painkillers. And they can be simple paracetamol and simple Nurofen anti-inflammatories where appropriate, over the counter. So anyone can be doing this, from the GP to the physio to the osteo to whoever's assessing and treating this patient. And then you have more prescription tablets. So for the paracetamol becomes coproximal, codeine-based tablets, and then coproximal, cocodamol, codidromol, and then you've got naproxen, which is a prescription anti-inflammatory. You've got meloxicam, which is a COX-2 inhibitor patient we use to treat. Diclofenac was a very good anti-inflammatory. They use it less because of the cardiac complications, but some people still use it. And diclofenac gel, people can buy and use it topically. And so these are global treatments all of us should be doing. So yeah, then you've got the outer layer of other things that have some benefit. Which is hot and cold, TENS, braces. We've done a lot, I think, on unloader braces. I've got some good evidence now for unicompartmental disease, medial or lateral, less good for patellofemoral. But someone who's varus with medial compartment disease and medial unloader, for lateral compartment, a lateral unloader. Then a knee replacement surgery, an osteotomy, i.e. knee surgery. Not knee arthroscopy is not a treatment for knee arthritis of any kind. Not the primary treatment. It could be for a loose body, it could be for a big meniscal tear with a bucket handle tear where arthritis is present but not as an indication. We don't do knee arthroscopy anymore for washing out, clearing out knees that are arthritic. Lateral wedge insoles, people have some evidence to support them. Acupuncture, but not much evidence. Steroid injections are included on that list, but what isn't included is PRP, platelet-rich plasma, hyaluronic acid, or the stem cells, and we discussed that as well, I think.
Very interesting, and I think steroid injections are always a topic that creates some uncertainty and things like that. Where do you stand on steroid injections for patients with osteoarthritis?
So I use targeted steroid injections for people to enable patients to do the central core, the stretching and strength, the exercise, If the exercises you as a physiotherapist would give a patient are too painful, then we need to look at the painkillers, from simple painkillers to prescription painkillers, not opioids, to injections. For the acute pain, the acute swollen knee, the big flare up, arthritis is in the knee and something's flared that knee up. The dragons have been woken in the knee by a trip or a meniscal tear or something that's caused the arthritis to spring to life and the knee to swell, and an injection is good for that. To settle the knee down, to get them back to the primary core treatments of the rehabilitation and the exercise.
Super, thank you very much. So we've talked about the non-surgical options. Let's say we have a patient now who fits the diagnosis for OA. They've had their imaging, which is consistent with advanced OA, and that you are considering operating on them. What different surgical options might you consider? Again, speaking globally, what kind of surgical options would you consider for your patients with OA? What are the different things they could have?
Yeah, so patients who have got proven osteoarthritis, then we divide it into the compartments. Is it medial compartment, lateral compartment, patellofemoral, or more than one compartment? And and then what's the patient? Who's the patient? Not just age, because we have 70-year-old patients who look 50 and we have 40-year-old patients who look 80. So what is the patient? What's their makeup? What do they want to get back to?
Sure.
So the biopsychosocial assessment of the patient is key, because if a patient who is 75 wants to play golf, that's a reasonable thing to do. A 75 patient who wants to do triathlons every week is not is a different conversation. It's not unreasonable for that patient, but their level of expectation after whatever surgery we might be considering has to be taken into account. And also the longevity of the patient, the size of the patient. Obviously, a morbidly obese 45-year-old who has a knee replacement, the life expectancy of that knee replacement is going to be less. So we have to weigh these things up. So not everyone the X-ray shows arthritis, knee replacement. It's not that easy and not that straightforward, and it shouldn't be. So this a la carte treatment for different patients is important because there's different options. So also, it's very important that whatever the patient with arthritis, whatever their age, always non-operative first. Always. So even the worst X-rays we see, we know patients can have no pain. It's one of the things I always talk about is that when you've injured your knee and you've torn something, you want to be at the front of the queue to get that fracture or ligament or whatever tendon that's ruptured fixed in whichever way you want to do it. You want to be at the front of the queue. But if you're worn out, be it your shoulder or your knee or your hip, be at the back of the queue. Go and do the core treatments first, and you'll get a better result from any surgery that's needed once you've done those core treatments.
Super.
So, going back to your question about what the surgical options. So, in a 57-year-old with unicompartmental disease, if he's active or he's a labourer and it's one compartment, the options of a unicompartmental knee replacement are there, but the life expectancy of that will be lower because he's younger and more active, and if he's a labourer, even more so. And so they're the patients we might consider an osteotomy on. Osteotomy. So typically the picture is varus compartment, medial bow-leggedness, and we make we osteotomize, cut the bone on the tibia, and we open up the joint here, and we realign the bone. So someone like me is bow-legged, I would become straighter, and you would offload the worn knee, and the load would go from the inner compartment to the outer compartment. And I don't know whether this will show up on the camera, but if I stand up, if I exaggerate my bow-leggedness, the weight would go from here straighter to the lateral compartment.
Super.
And vice versa for a valgus or a lateral compartment disease. That's an osteotomy. We break the leg, we fix the break. It's a controlled surgical break. We fix that with a plate, a strong plate that patients can mobilize quite quickly on. It's extremely painful, as you'd imagine me breaking your leg would be. Obviously we give painkillers, but the idea is these patients can exercise and play sport on these knees, and at some point, hopefully, it might defer or delay a knee replacement, but it's a better option for the active patient. Not the younger patient, but the active patient.
I like it.
As you get older, that patient with a unicompartmental disease, or the younger patient with unicompartmental disease who's got reasonable alignment, a unicompartmental replacement or a partial knee replacement, like this one, where we've only replaced the affected compartment. We don't know whether this is medial or lateral. Medial. The medial femur, the plastic which replaces the meniscus, and the tibia, and these are cemented on normally, but you can get uncemented, and it leaves the patellofemoral and the lateral compartment intact, and most crucially, the ligaments are intact. That's a very important point. ACL, PCL, medial and lateral collaterals have to be intact for a partial knee replacement. Okay.
Super. And I suppose one thing, if I may ask about the osteotomy you mentioned, if that patient then grows older, stops building, they're now 75, have we burnt any bridges for the potential of a TKR, or is that still on the table for these patients?
Yeah, it's still very much on the table, and it's definitely easier and better for the patient to go from an osteotomy to a total, or a partial to a total, than it is from going from a total to a revision total. But it's not easy. It's not like the native knee, because we've changed the biomechanics. And as a physio, you'll know that if I change the way your leg is shaped, all the muscle lengths have changed, the slope of the tibia changes, it's going to affect your hip muscles, your back muscles, your quads, and all the muscles below the knee, the calf. And so, yeah, it's not as straightforward, but it's a better option.
Certainly. Fantastic. So leading on from there in terms of the medial compartment, let's say, and or the lateral compartment, because of course, as you said, you can have an osteotomy that biases the medial or the lateral side. You can have a unicompartmental replacement which biases the medial or lateral side. And then of course, we've got the total knee replacement. Anything between those options, anything between osteotomy and TKR that could be a consideration, or is it mainly that if those two haven't worked so well, then a TKR is more likely?
Yeah, so people talk about joint preservation. And if we talk about that spectrum, where the end of joint preservation from our respect can either be a partial joint replacement or a total joint replacement, a joint sacrificing procedure. So an osteotomy is a joint preserving procedure. The knee joint is still yours. And there's quite clever things we can do with an osteotomy, like shift the top of the tibia to compensate for, we call that slope changing osteotomy, to compensate for the lack of an ACL or a lack of a PCL or an injured ACL or an injured PCL. So that's part of a joint preserving procedure. And also part of joint preservation is, remember that arthritis, if we imagine a joint of the body is, I'm just taking the patella off, is the bone, the femur, covered by hyaline articular cartilage. When this hyaline articular cartilage is worn out and the bone below it is damaged, that is arthritis. And it can be focal, i.e. patches, like 1 finger breadth on the medial femur is a focal defect, a focal chondral articular cartilage defect. And when that's diffuse, that is what arthritis is. It can be diffused within one compartment, unicompartment, or lots of compartments. So the joint preservation is reasonable for focal defects and malalignment, and joint preservation encompasses meniscal repair surgery, ligament reconstruction, treatment of articular cartilage, be it microfracture or chondrocyte transplantation. It could be allograft transplantation. So that's the whole spectrum of joint preservation. And those enthusiasts who talk about stem cells would put that into that bracket as well. And then once there's diffuse damage, we talk about joint sacrificing. So osteotomy is probably at the end stage or as a joint procedure in joint salvage, and then we go on to joint sacrificing procedures. But not everyone's suitable for an osteotomy. You know, people with reasonable alignment or diffuse damage, it's going to be a total knee replacement, or partial, depending on what more than one compartment. The other thing we need to talk about when we talk about osteotomy or unicompartmental disease is bracing, because I will brace anyone for an osteotomy. If they've got varus medial disease, I will trial them on a medial unloader, because that tells me that their osteotomy or their partial will work. It might be good enough for them not to have an operation at all. And we've done some research on that. And the same on a lateral compartment. So before an osteotomy or a lateral uni compartmental replacement, I would try an unloader. So that is a very good adjunct, very good for physios actually, to work out whether they want to refer this patient up. I don't want to go and see a surgeon, because we know there's a lot of people who do not want that surgery. Well, we could try an unloader. It would tell us, allow us to see if it's going to work. It'll also allow us to see how much better you will feel with that disease compartment unloaded. So I think that there is a role to play there.
That makes super sense. And as you said, it's a great way of I can see that you're not just thinking surgically there, you're thinking surgically, but also, there's an adjunct that we could fit into the middle of that, which is superb stuff. Okay, so how about for the patellofemoral joint? So if we, and of course, if you wish, talk about patients who have patellofemoral OA with the other compartments degenerative as well, or a patient who has isolated patellofemoral OA on its own. What kind of surgical options might you consider for them?
Okay, so again, the main treatment for patellofemoral OA is rehab. The core treatments stay the same, and in fact, even more important on someone with patellofemoral OA. They're normally the middle-aged patient. More often than not, it's they're female, typically bilateral, and for all you guys who become experts in patellofemoral pain, often there can be a lot of those other psychological issues with the patellofemoral pain. These patients are active, they might have young children, it can be disabling for them. But people have a strong psychological issue with arthritis when they're young. And in patellofemoral pain in particular, because often the radiology is not advanced. So why does mild to moderate chondral damage on the patella cause this patient so many symptoms? And the first, second, third line of treatment here is the rehab. So why am I, or given the impression as a knee surgeon, that all these other things are important? I tell you why, because after a knee replacement, the success rate is 80%. It's not 100%.
Absolutely.
So if you're busy and you have a waiting room full of patients and you do knee replacements in all of them, 1 in 5. It's a real number, isn't it?
Absolutely.
Are going to be dissatisfied. They're not. It's, the knee replacement hasn't lived up to their expectation.
Sure.
The complication rate is lower than 1 in 5, obviously. I think all the complications of a knee replacement, infection, stiffness, swelling, bleeding, blood clots, death, which is very rare, thankfully, all those things account to about 8 or 9%. But I think there's a 10% number that just do not like the new knee, doesn't feel normal, doesn't feel like part of them, and they just don't like it. So that's a real number, and therefore improving their range of movement, improving their exercise, getting their pain under control, even pre-op, as part of prehab, is a good thing. So that's why you want to wait.
Super.
Yeah.
Absolutely.
Don't wait too long. Don't be crying in pain and ruining your life. And I'm not putting people off. It's a very, very, very good operation when done appropriately for the right patient. We all know patients who've had knee replacements. My mum's had 2. I think your family members have had some. They are good operations for the right patient.
Absolutely. Super stuff. And that totally makes sense for your patellofemoral patient, especially when, as you said, muscles strength contributes so much to the patellofemoral joint. If you feel that patient has exhausted that conservative pathway. What kind of options might you consider for them?
Okay, so a partial patellofemoral knee replacement is quite good. So we just, again, resurface the back of the patella with a bit of plastic, and we resurface the top of the trochlea with a metal plate, often cemented in, and that articulation, the up and down stair articulation, the sitting to standing articulation, the uphill, downhill articulation improves. And that can work, and it can work very well in the right patient. Again, all the other ligaments have to be intact, the menisci have to be intact, and the medial and lateral compartments have to be intact. And a patellofemoral replacement, like most units, can last a good amount of time, 10 years, 8 years plus. Again, the factors that wear out a partial knee replacement, weight is very important on the patellofemoral joint. So you want to keep that weight down, and a patellofemoral replacement's good. For focal damage, there is an osteotomy we can do for the patellofemoral joint. So this model, quads tendon, patella tendon, attaching to the tibial tubercle, we can, in certain pathologies, more focal damage on the patella, lift the tubercle, an osteotomy, a tibial tubercle osteotomy. We break the tubercle off and either move it anteriorly or distally to offload a part of damage on the patella. So in effect, we can do that, and move that tibial tubercle around. So the osteotomy is also valid in a patellofemoral, but much less frequently.
Absolutely super. Thank you so much. And I guess if the patellofemoral joint is extremely degenerative with the other compartments, then the natural suggestion might be a total.
Correct. Some people are selectively doing more than one compartment, like a uni compartment in the patella, a uni compartment on the femur, and then later, if necessary, you can add a uni compartment in the lateral. This is newer technology, doesn't make it any better, but the idea there would be they can preserve the natural ligaments.
Sure, yeah, which as you said earlier is extremely important.
Yeah, but in a total knee replacement, we do sacrifice the ACL and some sacrifice the PCL, never the medial and laterals if possible. In these unis of any kind, they're preserved. So the idea being they feel more normal. Okay.
Absolutely super. Right, Mr. Trikha, so we thought we'd bring some ideas and some case studies into it just to kind of explore some of that clinical reasoning again. Now, the first case study I have is someone we've probably talked a little bit about, so we might fly through this one. So our first case study is a 55-year-old male builder. He has advanced osteoarthritis, but because, as you mentioned earlier, because of his age, because of his job and the demands that he wants to place on his knee, you may feel a total knee replacement isn't suitable for him. What options might be available?
Okay, so for that guy who's medial compartment, unicompartmental disease.
Sure.
Yeah, so we're talking about obviously assessing, we've established his activities of daily living and struggling, he's got advanced OA of the medial compartment. So as part of the assessment, slightly different for him, you'd want to consider long leg alignment films. Okay, so good. Long leg x-rays. Yeah. Because you want to see if there is, if the mechanical axis or the weight-bearing axis is going through the medial compartment, and is he a candidate for an osteotomy? And the reason we're thinking about this is he's active, he's a labourer, he's going to run around on this new surgical insult, and an osteotomy is more appropriate in patients like that than a partial, because he'd wear that out, probably.
And I suppose that's a really important point to mention, that those kind of activities, whether it be walking, running, building, are still possible on an osteotomy.
Correct. But a 55-year-old with tricompartmental knee arthritis who's severely affected would also do well with a knee replacement. Okay, cool. So with tricompartmental disease, we know that people are more active. We also know patients are much more obese. So we're getting a lot more arthritis. And so, yeah, so it's a good option, the osteotomy or the partial, but in this guy, a 55, 57-year-old labourer with unicompartmental disease, think alignment, and confirm that on long leg x-rays, and think osteotomy.
And if you were going down the total knee replacement route, would you be having quite a chat with him about expectations and what he can do with his knee?
Yeah, of course. And if he's done all those things, and particularly the weight you'd want to keep down, you know, the mental picture of a 57-year-old builder is a big stocky guy. He might not be, but obviously, you know, you want to think about that and a degree of expectation. Yes.
Cool. Superb, fantastic. So our second case study is a 67-year-old lady. Now she also has clear and significant osteoarthritis on her medial joint line and her lateral joint line. So she's more in keeping for a total knee replacement. However, she has a history of rheumatoid arthritis. How might that change your thinking?
So in terms of assessing a patient on their arthritis, as we've discussed, and the same treatment protocols will go ahead if she's severely agonized by the pain and it's affecting her quality of life and activities of daily living. The one thing differently here I'm thinking is I want a rheumatologist to see the patient if they haven't seen one, because the modern rheumatology drugs are very good, very powerful in controlling pain, and they are evolving all the time. So get a rheumatologist to see the patient. More often than not, patients with established rheumatoid arthritis have seen them before they come to me. But if not, make sure that happens. And as a physio, if you're seeing a patient who's now a candidate for knee replacement on their rheumatoid, maybe a rheumatologist might be the first port of call rather than straight to surgery. Because as you know, rheumatoid arthritis can affect many joints. And you know, we all know patients who've had both shoulders, both hips, both knees replaced, both ankles fused, and it's an ongoing saga. But nowadays, that's a lot less frequent because of the medication they can take. Technically, from a knee replacement, I'm much more likely to do a total knee replacement because of the bone, and the rheumatoid bone, in theory, may not be as strong, so maybe a definitive cemented total knee replacement. I would definitely do the patella as well and resurface the patella, even if it was good, because you don't want that wearing out subsequently. There are other technical things we do. Historically, we'd use a certain type of knee replacement where the PCL is taken and substituted for, so the PCL doesn't give way later. Okay. If you do a PCL saving knee replacement, and then with the rheumatoid, it's more likely to rupture, that kind of things we think about technically. But the key learning point there is what other joints are affected. And so you want to check the other joints and also make sure the rheumatologists have given an opinion on this patient to check they're optimized.
Brilliant, thank you. You've touched upon there that the bone quality is obviously a significant part of your thinking there. Is implant rejection or perhaps an autoimmune response to the implant, is that a factor as well?
Yes, that's happened much. It's almost come upon us this over the last few years. Nickel allergy is what we do get. And so patients who are often allergic to cheap metal, cheap jewellery, we found that there was an increased instance of those patients having either some inflammation around the knee, or there was an increased number of those patients who just didn't like the knee. You know, the 10% I mentioned earlier don't like the new knee. And so we do ask that question on every patient now. Do you have any sensitivity to metal? Because we can use nickel-free implants now in the hip and the knee to counter those patients. So not really rejection, but an allergy to a component within the metal, and we can do that.
Super stuff. And then our final case study, I suppose, is one that physiotherapists might find themselves coming across often, and dare I say it, perhaps you may have as well. We have a 79-year-old lady, and she has right-sided knee osteoarthritis. She also has right-sided hip osteoarthritis. May I ask what kind of considerations you might have for this kind of patient?
This is a very important question, because every knee surgeon I know will see a patient who's had a knee replacement, looks good on x-ray, and someone sent them to us, or the patient's coming in and going, my pain's still there. And you wiggle the hip, get a hip x-ray, and the hip's arthritic. Because we know that hip pain can be referred to the knee. So as part of any knee assessment, you have to examine the hip. You don't have to x-ray it, but rotate the hip. Do a Trendelenburg, do adduction, abduction of the hip, check the flexion of the hip as part of, I often do it as part of the meniscal tests, and when I get them to squat, I'm assessing the hips, and if there's any groin pain or they're reaching to the side, get a hip x-ray as well. So it's important. So when we have established hip arthritis and established knee arthritis, typically you would deal with the hip first.
Okay, interesting.
Typically, if they've got some element of hip pain. If they are adamant that it's the knee, my hip doesn't hurt, doctor, but your hips are worn out on x-ray, but my knee hurts. And you see good reason on the knee, because the knee's worn out as well. That's where a targeted injection might help.
Okay.
Not steroid, just a bit of local anesthetic.
Okay.
Because if I inject the knee and all the pain's coming from the hip, the pain should stay there. The pain will still be there. And likewise, you can inject the hip. And some people do that for hip arthritis. So they inject the hip, does it work? Yes, it does. You know the surgery would work. Okay, I don't think we do it in everybody, but that's a nice little trick to have some local anaesthetic injected into the joint to see if the pain goes away.
Very interesting.
But the hips are normally done first. Likewise, a knee arthritis and an ankle arthritis, you want to probably deal with the knee before the ankle.
So everyone, we really hope you've enjoyed this video, and if you have, then please support us by smashing that like button. And I know that Mr. Trikha will be doing loads more with us in terms of clinical reasoning, but if you haven't seen them already, check out his subjective and objective assessment videos, which are brilliant watches too. My name's Khalid Maidan, thank you so much for joining us, and we'll see you really soon right here on Clinical Physio.